So we've had some new studies, and some of them are being presented at this ESMO meeting. What are your thoughts on some of these new abstracts? The data is just coming out now.
Mm-hmm. No, listen, I think it's an exciting time in neuroendocrine cancer. It's only been in the last decade that we're starting to see abstracts come out and randomized trials come out from an evolving treatment landscape. You know, PRT, there's still, as we have alluded to, many unanswered questions about when and how and whether we should retreat, for example. We have a number of trials coming out on targeted agents that in both pancreatic and GI neuroendocrine tumors, such as cabozantinib and other targeted agents. Some are just recruiting, some are ready to report. Immunotherapy is, of course, all the rage in all the oncology world, and we have starting to get our first immunotherapy results starting to come out. We previously saw the Keynote trial, which showed fairly modest response rates in a very limited population. So I think I was hesitant to make too many conclusions on that. It was 12% in the GI population and 6% in the pancreas population. We have coming out in the next days here at ESMO, the largest immunotherapeutic trial coming out in neuroendocrine tumors, looking at PDR001 in patients with neuroendocrine tumors of pancreas, gastrointestinal, thoracic, as well as poorly differentiated neuroendocrine carcinomas. I think that is going to be interesting to see what the responses are, as well as the duration of response. I think when it comes to immunotherapies, it's going to be important for us to delineate who the right patients are. I think we still have work to do to try to understand who could potentially respond to immunotherapy, or how we can make the tumors, on the other hand, more responsive. How can we make them more inflammatory so that we can have responses to some traditional immunotherapeutic agents? We know at baseline that neuroendocrine tumors generally don't have a high mutational load, and the results so far have not shown dramatic effects of immunotherapeutic agents such as PDR001, but I do think there's probably a role to play, potentially in lung neuroendocrine tumors especially, where there may be certain patients that would respond quite well to immunotherapeutic manipulation, and there may be other things that we can do to improve that.
I agree. I mean, the data with immunotherapy has been underwhelming. With PDR001, the highest response rate was seen in atypical lung neuroendocrine tumors, but approximately 20%, but in most cases not durable. And then in the remaining cohorts, it was pretty much single digits. And I think there was some surprise also that we haven't seen too much response in poorly differentiated or high-grade neuroendocrine carcinomas, where we were expecting to see more responders.
I mean, I think it's important, the response rate in the thoracic cohort for the study was 20%. All of the people who responded were atypical. Yep. So if you take the atypical lung neuroendocrine tumors out, it actually the response rate starts to go up. And there's still patients undergoing treatment. These are still preliminary responses. So I do think, my interpretation would be that it definitely shows some promise. But you're right. I think we still have to truly understand how we can improve the efficacy of neuroendocrine tumors, especially in this unmet need of neuroendocrine carcinomas, where really we have a shortage of treatments.
What about lenvatinib?
Sure, I was going to ask you, if there's any. I mean, the lenvatinib results haven't been fully released yet, but I think from what we've seen in an abstract form, they do appear to be exciting. And I think, again, I think we're starting to understand how more of the targeted agents beyond some of the traditional ones we use can be exciting. I'm not sure. As a single agent, we know exactly where it needs to go quite yet and where it would sequence in, and potentially as a combination therapy. I don't know, do you have any thoughts on that?
Well, I just looked at the abstract, and like you, I haven't seen the presentation yet, but the response rate, the objective response rate, was exceptionally high. I think it was roughly 40% in pancreatic nets, I think 18% in other GI nets. So definitely higher than what we've seen with other targeted agents. And I think, for a phase 2 study, response rate is really an important endpoint. It's hard to know what to make of PFS in a phase 2 study just because of the heterogeneity of the population. But but a high response rate is sort of a strong endpoint for a single-arm study. So it's very encouraging, I think. And I have no doubt that we'll be seeing more randomized studies with lenvatinib.